you for the invitation and the opportunity to speak here. Apologize, I can't speak Spanish. I've been in California for 3 years. I should be learning Spanish, but I'm not there yet. So hopefully the translation works. Dr. Oliveira went over some of the things that I was going to say, so I'm going to skip over some of the material that you eloquently addressed so I can save some time. So I'm going to talk about just very basic. I am given the title ABCs of immunosuppression, so I'm going to be very basic. I'm going to talk about alloimmunity in liver transplantation, principles of immunosuppression, different classes of immunosuppressive drugs, and talk about protocol putting those together. And then if I have time, I'll touch briefly on managing acute cellular rejection. So this is a really basic transplant immunology. There are two cells that are very important in liver transplant immunology. The first one is antigen-presenting cells, APCs. Those are professional cells, typically dendritic cells, but Kupffer cells in the liver that present the foreign antigen that's in the donated liver to the recipient immune system. It stimulates immune response thereof. Then the second components that are very important are the T cells. They are either CD4 or CD8 positive. CD8 cells in this context are cytotoxic T cells, and CD4 cells are helper cells, which recognizes foreign antigens by their T cell receptor. It produces cytokines stimulating immune cells, so cytokines such as IL-2, induces lymphocyte proliferation. It promotes maturation of cytotoxic T cells, and it stimulates CD4 T cells to make other lymphokines and interferon gamma type cytokines. There are other cell types such as natural killer cells, polymorphonuclear leukocytes, monocytes, and macrophages that completes the picture. So this is the picture. You recall that the liver is donated liver. This is not the recipient's own liver. This has a foreign antigen. And that foreign antigen is processed by antigen-presenting cells, and they are presented to immune cells that are located in lymph nodes. These are lymph nodes, and then they interact with T cells and other immune cells, which is here. There's a propagation of the immune reaction within the immune system, and those activated cells come back to the liver, trying to do something in the liver, and that is two of the either reactions. One is acute cellular rejection, as it can be seen here. So the graft is rejected, or there can be adaptive response where the two entities, the host and recipient, learn to coexist. That's the key word in transplantation these days, called adaptation. So if you look in the lymph node, this is what you will see. And this is a complex cartoon, but I'd like to point out just three things. There are three ways for the antigen-presenting cells and the T cells to interact with each other. The first one is MHC type 2 mechanism. This is a HLA type of reaction. That's important. And there is a second reaction called co-stimulatory pathway. And then there's a third reaction that's CD25. All these are three ways the two cells to interact with each other, causing immune reaction. So it notes here cyclosporin and tacrolimus working along the signal 1 type pathways. There is a sirolimus, everolimus type of medicine that works in Mtor pathway, which is in the third category. And then this further leads to cell cycle disruptors, such as MMF or azathioprine, that I will talk about later in this talk. So why do you need immunosuppression? That's kind of a dumb question, because otherwise there will be allograft damage. And the damage is predominantly caused by cytotoxic T cells. In the liver, the predominant effects are in two locations. One is in bile duct cells, and the other are endothelial cells. So that's where rejection occurs. That's where our pathologist will look for signs of organ damage. In order to prevent the damages, you need immunosuppression, and the immunosuppression does depletion of lymphocyte and lymphoid organs, diversion to alter, traffic, and sequester immune cells, and thirdly, inhibition of non-redundant steps. As we saw in the last picture, there are many steps in the immune interaction, and you want to interrupt that. Dr. Oliveira talked about something similar to this. There are different phases in the immune reaction. In the induction phase, the first month or so, the recipient and host interact with each other. So they get to learn each other. If the interaction is pretty aggressive, then you can result in rejection. If it is more friendly, then there is more easier coexistence between the two systems. And as the two entities get to know each other, your requirement for immunosuppression becomes lower, and that becomes the maintenance phase. So the instance of acute rejection is highest, and mostly in the first month, maybe up to a third of the patients, and then it becomes progressively smaller after that. Globally, when you think about how to optimize immunosuppression, you want to achieve stable allograft function with least amount of immunosuppression and minimize toxicity. So on the one hand, you want to preserve immune allograft function by preserving the integrity of the organ and avoid damages. That is done by giving more immunosuppression. But if you give too much immunosuppression, then you will have toxicity. And Dr. Oliveira talked about infection being one of the toxicity, malignancy being one of the other toxicity. Then there's a drug toxicity, such as renal toxicity, diabetes, and so forth. So you want to manage those two things. And on a day-to-day basis, what we look at is a patient's ALT levels, where they are, and their creatinine, blood glucose, and other things that are secondary effect. You're trying to maintain the two at an optimal balance. The goals of immunosuppression in the early phase is to prevent parenchymal destruction long enough to allow adaptation. In the late phase, we want to propagate and stabilize the adaptation, called adaptive tolerance, so that the two organ systems work together. The administration of immunosuppression is kind of an art. There are a few issues. One, we don't have a good biomarker that says, okay, this patient is in good balance between the two things that we're trying to balance. The only tool that we have is the trough level for the immunosuppressive drugs. And that is not very accurate representation of the overall status immunosuppression. There is no marker for tolerance, and rejection and alloreactivity, there isn't a blood test that tells us that there's a rejection going on. There is a poor correlation between rejection and the degree of abnormalities in liver function test, and there's a poor correlation between rejection and immunosuppression levels. So again, this is where the experience of the transplant hepatologists come in, that you look at the patient and lab data overall and make a decision whether you need more or less immunosuppression. There's no non-invasive markers of rejection as we talked about. Liver biopsy remains the gold standard. Transaminases, alkaline phosphatase, those kinds of blood tests are non-specific and not directly indicative of rejection. There are several kinds of immunosuppressive drugs. Glucocorticoids is widely used. The second is small molecule drugs. The first kind is cell signal disruption drugs such as calcineurin inhibitors, which include cyclosporin and tacrolimus. The second, which is increasingly used, are Mtor inhibitors, including sirolimus and everolimus. The second kind of small molecule drugs are inhibitors of immune cell proliferation, such as IMPDH inhibitors, including mycophenolic acids, and anti-metabolites such as azathioprine. And there are more expensive, more involved protein drugs, such as anti-thymocyte globulin or OKT3 that deletes certain types of T cells. They are deleting antibodies. Then there are non-depleting antibodies, anti-CD25 antibodies such as basiliximab. And then more recently, fusion protein CTLA4, which works on the second pathway. Belatacept is one example of that. So I'll skip that cartoon. So I'll just go over these individual categories briefly. Calcineurin inhibitors are cyclosporin and tacrolimus. They are usually given twice daily. Again, we measure trough level, which is 12 hours after the dosing, the last dosing. We measure then that, use that as a guide, whether there is enough drug present in the system. There's significant drug interaction with cytochrome P450 system, so you need to be aware of drug interaction. There's synergistic toxicity with some of the antibiotics listed there. Antifungals, ketoconazole is famous for raising the level of these medications, and there's some interaction with NSAIDs. So when you use these medicines, you need to be careful with other drugs. Adverse effects are fairly numerous for calcineurin inhibitors, and this compares cyclosporin and tacrolimus. And you can see the renal toxicity is common to both drugs. Hypertension is more common with cyclosporin. Obesity is more common with cyclosporin. Hypercholesterolemia, including cholesterol and triglycerides, are more common with cyclosporin as well. Both drugs cause diabetes and osteoporosis. So sometimes we need to switch from one medicine to the other. Cyclosporin is the older drug, and Prograf is used more commonly. And these are some of the cyclosporin unique side effects that trigger switching from cyclosporin to tacrolimus. Mtor inhibitors, everolimus or sirolimus, are used in conjunction with or in lieu of calcineurin inhibitors. We sometimes measure trough levels, but not necessarily. Mtor inhibitors are somewhat unique. It has anti-tumor effect. So if you have patients with hepatocellular carcinoma, sometimes that is used to suppress the tumor regrowth. There's anti-fibrotic effect. So some hepatologists consider using sirolimus type medicine for PSC patients to reduce recurrence. And then it doesn't have the renal toxicity that calcineurin inhibitors have. So patients with renal abnormalities, these medicines may be helpful managing those patients. On the other hand, Mtor inhibitors can cause hepatic artery thrombosis in the early phase of transplantation. So FDA has a black box warning that says these medicines should not be used in the first month after liver transplantation. It has anti-fibrotic effect, and by the same token, it delays wound healing. So if a patient who has a liver transplant needs a second surgery of some kind, these medicines are not good for those patients. We switch them back to calcineurin inhibitors temporarily for the operation. There's some increase in infection rate as well as further risk of hyperlipidemia. There are two antiproliferative agents that are used. Azathioprine is an older drug, and mycophenolic acid is a newer drug. They both inhibit purine DNA synthesis and therefore inhibit proliferation of T and B cells. It has merotoxicity, some malignancy potential, opportunistic infection, and GI toxicity, including diarrhea and dyspepsia, which occur with mycophenolic acids. Corticosteroids, you are very familiar with corticosteroids. It inhibits cytokine transcription. As you know, there are numerous side effects: hypertension, diabetes, hyperlipidemia, osteoporosis, altered mental status such as anxiety or sleep deprivation, cataracts, acne, peptic ulcers, and infections. So we try to avoid using corticosteroids too long. The principles under which we do liver transplant protocol is to control versus eliminating alloreactivity. We want to minimize toxicity, so we want to reduce the number of agents and doses as quickly as possible and individualize management when possible. We also want to minimize recurrent disease. Hepatitis C recurrent is not as a big deal these days as before with the effective medicines, but other diseases also recur. We want to use evidence-based data to choose regimens and then also consider cost effectiveness. Combination therapy of these different medications is preferred because it inhibits immune response at multiple sites. It allows lower doses and levels. It reduces dose-dependent toxicity, and it also lowers rejection rates. Rather than listing the details of protocol, this is what I wanted to show you. For prednisone, we start with 50 milligrams on day 0. It's tapered over a 6 months period, and then everybody's off prednisone between 3 and 6 months after transplantation. We initially use mycophenolate. That is also discontinued at about a year. We tend to shorten it in patients who don't have rejection. We may prolong it in patients who have more severe acute rejection early on. We use high levels of tacrolimus up to 15 nanograms per ml in the first month of transplantation. That is gradually reduced. By the first year, at the end of the first year, we will have tacrolimus monotherapy with a target level around 5 nanograms per ml, and patients do well. This is acute cellular rejection. Again, it damages bile ducts. Here you can see a bile duct here. There is a bile duct cell that is dead. There are a lot of cells infiltrating around the bile duct. That includes eosinophils, which are characteristic. And then endothelial cells are lifted up by reactive T cells, and that indicates damage to the venules. Management of acute cellular rejection is pretty standard. A biopsy is essential. You can't diagnose acute cellular rejection without one. However, not all acute cellular rejection needs to be treated. Mild cases may be treated with just increased immunosuppression. In patients who have moderate or more severe rejection, we use corticosteroids, which is the first line, methylprednisone, 1 gram bolus, about 3 times is used. This is followed by rapid taper. In patients who are refractory to steroids, thymoglobulin will be the first line of treatment to go to. We need to make sure that the immunosuppression maintenance is done at an appropriate level, and the patient must be on a higher level at the end of the treatment than when the rejection occurred. So it doesn't make sense for someone to go back to the original rejection immunosuppression level when the patient rejected at that level. We need to go up and then try to take the person down later on once rejection is resolved. So I'd like to summarize that cellular immunity by T cells is central to graft rejection. The goal of immunosuppression is to prevent allograft destruction while minimizing systemic toxicity. There are 2 phases, at least 2 phases. One is induction versus maintenance. Induction, it's more to prevent rejection. Maintenance is to promote adaptation. The main classes of immunosuppressive drugs we talked about: calcineurin inhibitors, including tacrolimus and cyclosporin. The alternative medicines are Mtor inhibitors, including everolimus and sirolimus. The second class is antiproliferative agents, mycophenolic acid or azathioprine, and corticosteroids we haven't been able to get rid of completely. The principle here is to combine treatment with a progressive reduction in the number and doses of immunosuppressant So by the time you're a year, 2, 3 years out, you will need to be on minimum doses of single immunosuppression drug, hopefully. We talked about management of acute cellular rejection, which consists of temporary intensification of immunosuppression. I hope this was not too basic for you. I think you're a pretty sophisticated audience, but this is a task that I was given, so I'm happy to entertain any questions afterwards. Thank you very much for your attention.